Hi, and welcome to the September 2025 issue of iGIE. My name is Phillip G., editor for iGIE's section on historical considerations. It takes an open mind to innovate novel subspecialties. While many in our field have become experts within our own specialty, it takes a completely different mindset to develop a novel niche. Within the diverse field of gastroenterology, the procedural world of advanced endoscopy is arguably as opposite as it can possibly get from the medical world of inflammatory bowel disease. Yet, there are those people who are not just innovative, but who have trained and collaborated across specialties and therefore possess the vision and the ability to successfully marry these seemingly disparate fields to create entirely new ones. We are therefore excited to tell the story of Dr. Shen, who is our distinguished guest for the Historical Considerations section of iGIE. Dr. Shen grew up in China, where his father's pioneering epidemiological work with liver cancer inspired him to pursue a career in gastroenterology and GI pathology. After coming to the United States and training at multiple institutions, he ultimately completed his fellowship at Cleveland Clinic, where he was inspired by academic mentors in gastroenterology and colorectal surgery to train simultaneously in IBD and advanced endoscopy, a highly unusual and unique academic pathway. It was at Cleveland Clinic where Dr. Shen successfully morphed IBD and advanced endoscopy together to become the world's preeminent leader in a novel field that he has termed interventional IBD, a field that is almost singularly associated with his name and reputation. Over his subsequent career, he established truly novel concepts, such as the subspecialty pouchitis clinic, the interventional IBD unit, and the IBD board, modeled after multidisciplinary tumor boards, to help manage the most challenging cases in IBD with multiple subspecialists. Dr. Shen served as the medical director for the Center of Inflammatory Bowel Diseases and the Ed and Joey Story Endowed Chair of the Digestive Disease and Surgery Institute at Cleveland Clinic, where he became internationally renowned as a pioneer in interventional endoscopic therapy for IBD and ileal pouch disorders, developing endoscopic techniques to postpone or eliminate the need for surgery in these conditions. After moving to Columbia University Medical Center, Dr. Shen is currently Professor of Medicine, Director of the IBD Center, Co-Director of Columbia's Global Center for Integrated Colorectal Surgery and IBD Interventional Endoscopy, Vice Chair for Innovation in Medicine and Surgery, and the Edelman Jaroslawski Professor in Surgical Sciences. Dr. Shen has participated in numerous clinical and translational research projects funded by the NIH in IBD and pouch disorders, and was the recipient of the 2023 Distinguished Clinician in Academic Practice Award from the AGA and the 2025 Suzanne Rosenthal Humanitarian Award from the Crohn's and Colitis Foundation. Dr. Shen, thank you so much for taking the time to do this interview. It is truly an honor and privilege. Tell us about your background and how you ended up becoming a physician.
Thank you, Phil. And I really appreciate this opportunity from our senior associate editor, Dr. Kerr, and also the editorial board of the iGIE. So I planned to become a doctor at a very young age because that time, 1960s, 70s, there's the high prevalence of liver cancer in my hometown called Qidong, Qidong. And at my time, my father was the founder of the Qidong Liver Research Institute. So as a young child, our house, our apartment, they frequently visited by the professors, physicians, epidemiologists, bench scientists from the larger cities such as Shanghai, Nanjing, and Beijing. So this is the start. It started almost like the late elementary school, early middle school. So I'm inspired to become a doctor and a scientist and try to figure out initially it's a liver cancer.
What were the leading theories at the time in terms of why the area that you grew up in had such a high prevalence for liver cancer?
This, as we know, this liver cancer is mainly resulted from from the hepatitis A, hepatitis B, hepatitis C later on, but this before 1970s, the viruses were not identified. The theory at that time is aflatoxin and water contamination, little bit of air pollution, and then mainly is a food contamination, especially aflatoxin. So that time is ketone is located in Yangtze Delta area and very humid weather, especially in the harvesting season. So the locals grown these large grains such as the corns and the peanuts and the soybeans, and the weather, they are naturally dry, not like from the machine. So they are the moist during the harvesting season. That's easy to grow the fungus with the aflatoxin. That is before late 70s, before the discovery of hepatitis B.
Interesting, and that actually coincided, from your standpoint, kind of coincided with you going into medical school, right? And I think you were part of what has actually been amongst Chinese circles is famously known as the class of '77. Tell us about this class and about your medical training.
Thank you. So this is the tough one. That I'm not one of the highest scorer. Probably during my my exam, I didn't do well, but I marginally has made to the medical school. I believe that my score one of the lowest during that during the exam for the exam. This is related to the Oxford Cultural Revolution, and 10 years in between 1966 and 1976, there's no college or medical school regular admissions. And at that time, so once new leader, Mr. Deng Xiaoping, become the leader, and he changed the system. So there in 1977, and all of a sudden we accepted the college and the medical school applications. So they were cumulative 10 years. The applicants actually exam take the 2 times, and then it's just one the 2 times shot. And the first one you are screening, and you'll be removed from the list, and they try the next year. And the lucky one moved to the second step, and you go there and then take an exam. Actually, we are the only class take exam not in the summer, it's in the winter. So all college medical school admission date is March, instead of in September. It's the only class in the history in China, probably in the world. We have a class started at the school is in the early March that year.
It's amazing. Actually, when you think about it, it's already competitive enough to get into college in China. To get into college, they're in that class. I mean, you were definitely, whether you think you're at the top of the class or bottom of the class, the fact that you got a medical education anywhere in China already speaks volumes in terms of your academic potential and your future career potential. So, it doesn't surprise me that you were part of such an historically significant class at the time. Now, tell me a little bit about medical school and about the mentors that you had in medical school, and how you became a GI doctor from there.
Thank you. It's the China the medical school system is similar to the British system. It's you finish the high school, then you do the 5 years or 6 years medical school. In all medical school, the 5 years. Then after 5 years medical school, you do the postgraduate course. Like myself, I do the 3 more years after the graduation from the medical school. So the medical school, it's very tough. Actually, you have 8 person in the dorm. Everybody study very hard and very competitive. I believe that in my medical school, there's we call lights off. October, excuse me, not October, 10 o'clock at night. So, and 10 o'clock, the whole school, the lights are off except the load lamp. So why? Because the 8-person dorm, we have a different age people. The old student, the oldest one is 32 years old.
Wow.
Youngest one, like myself, the 15 years old. So that we have a different biological clock. They want to sleep early, wake up early. The younger one wanted to sleep late, then they wake up late. So how do you keep it consistent? 8 people, because we have a noise, actually, I tell you. It's just, I have insomnia, difficult to sleep. I take the Valium to go to sleep.
Oh my goodness.
It's very competitive. It's a study very hard because we appreciated the opportunity, because it's very hard to get, and study is truly very hard. And then during even the internship, it's very hard too. You have to rotate it with in the different divisions. And basically, during my surgical rotation, in order to get the chance to have surgery, you basically sleep in the conference room, waiting for the emergent cases, so you can do the surgery with your teacher. So, and then the study very hard. Actually, also one important one, during our college exam, the medical school exam, we the foreign language or English is not required. So our class and the people has most of them has a little bit of difficulty to mastering the English. At that time I was working very hard, tried to use English to write the H&P. So there is a very unusual. So, but we learned in a very, very hard way. And then how I learned to use the computer to later on to learn English. Actually, the typewriter. It's a typewriter. You use a typewriter keyboard to learn English, to type English and speak. Actually, you also listen to the VOA Voice America to learn English. Yes, and then another called a new concept in English. So it's it has hurdle, and but we overcame. And then later on, they saw my class is 130 students. 20 of them is considered the top student. They start work in the university hospital. So these were the 20 of the 130, and this I was my first choice is a gastroenterology, because I want to become a liver doctor, become the liver cancer doctor. So I become the resident first. In China at that time, the resident is a permanent job. So you assign a resident as to the 3-year up to 5-year residency. You do internal medicine that rotate in different departments. The last year that I was elected as the first one of the 2 first chief resident in the history of our university hospital. I stay in the hospital, live in the hospital. Actually, my office is my office is my dorm. I only live there a year. So you do all the consultations, do admissions, and also you do the residencies. You act as an assistant to the residency program director. You give the exam. It's making the schedule. So it's tough way, but it's like very, very useful. And during the during residency, you get to finish the graduate school. The 3-year graduate school is very helpful. You get a master's degree, and all hands-on. You do that. That time you heard of HPLC electronic microscopy just started making, and then so we all hands-on. And so the one thing we try to learn the graduate school is not as good as we perform. It is the computer programming. I have no
Okay.
idea how to use computer. I know try to learn how to use the computer rather than programming.
Right, right.
As a medical person, I'm not good at that. So I'm glad that I got over it. It's a very intense training. All the training is tough. In the meantime, I met my mentor. Especially the mentor is Dr. Shen, and he is actually from the Christian family. So it's very caring and very gentle, and even during this Cultural Revolution, remained academically very productive. I remember that during the Cultural Revolution, he and the other doctor that published about around 100 papers in Chinese. It's a very unusual. So you learn the way he's a truly influenced and it is him later on sent me to study the GI pathology with his brother, who is a Shen man, and in the graduate from Loma Linda University Medical School, and one of the founder of the GI pathology in the Catholic Medical Center in Dayton, Ohio, also the adjunct professor at the Wright State University. So.
I see. Okay, so and I'm guessing that's your path in terms of how you ended up coming to the United States. Then was through Dr. Meng and his brother.
Yes, brother. It's actually they pay the salary out of the Dr. Meng's pocket.
Wow.
So that's always grateful. It's always grateful. They give me opportunity and learn. And then another pathologist, Dr. L. Patata, who's a chairman in Wright State University. So that's with Dr. Patata, we do the flow cytometry. Actually, I was the first generation of this learned how to run flow cytometry to the lymphocyte population, things like in the GI and the lymphoma. They're very, very helpful, all hands-on. And in the meantime, we have a paper I still remember. I used the Texas instrument, the calculator to run the stats. So that's a texture. Always remember that calculator is the best. So before that time, the computer screen is all the letters are green.
Right.
So that time is really old. Yeah, so then you basically polish your skill from the bench science and polish your skill from the stats. So that's why you train in the wide spectrum from the bench science, translational, clinical, later on outcome.
Yeah, and I think that, it's interesting. First of all, I still remember my old Texas Instruments calculator as well. But second of all, in all seriousness, it's very interesting how when you compare the story that you just told of how you trained versus how training is now, your training was so broad. You had a very, very diverse set of skills that you learned in the course of your training. It's a very broad skill set. And I think that has given you, my guess is that has made you a lot more comfortable when it comes to breaking boundaries and crossing boundaries in terms of what you did later in your career. So you came to the United States and to train with Dr. Meng's brother, and then you decided to stay. So tell me a little bit about staying, how you, what made you decide to stay, and then your subsequent training, and all the way up to what led you to Cleveland Clinic.
So this time, with Dr. Patata and Dr. Meng, we published a bunch of the articles together. At that time, it was given the research assistant professor in Wright State. Actually, the life is not bad. It's like comfortable. But Dr. Meng mentioned, said if you really want to take care of the patient better, you have to take boards, have to be a clinician, and to become a clinical scientist or physician scientist. So I take the board, and then score is okay. So I get accepted at the University of Illinois at Champaign, Urbana. So I did my 3-year residency there. Also had a good training there. So that's actually the previous education training is not wasted. So then 3 years, and then applied the GI fellowship. I think that when we applied the GI fellowship, it's in mid-90s. Actually, that time, because of my managed care, actually GI fellowship match program is collapsed that year.
Wow.
So not many people apply. At that time, I believe this primary care physician's income is better than specialty. So that's not many people try to add an additional 3 years of fellowship. But I'm the gastroenterologist in China that already had the background. They said I don't waste my previous training just to become the primary care doctor.
Right.
I'm also interested in the science, and so that's why I applied the GI fellowship. So then fortunately that time is my fellowship program that Dr. Gary Falk. Dr. Falk said it's like, Bo, I only give your 24 hours. You come or not come to the Cleveland Clinic. So if you don't, it's very tough. He said, if you don't want to come, it's actually that time. My wife is working in Indiana. So actually, my best the intended program is Indiana University. But I didn't get interviewed. I think that there's a time, so that I'm waiting for the Indiana. So that's that time at the Cleveland. Probably I don't say maybe they're politically right or not right, because that time Cleveland its city has a not great reputation. River on fire, and the things crime, things like a little bit of nerves that time. And it turned out to be Cleveland Clinic is one of the, I would say, the best institution in the world. It's like we have a wonderful training.
It is, yeah.
It's like we said, Cleveland later is a city. Nobody wants to come, but nobody wants to leave. So actually, that's the end of the truth. So that we later stayed in Cleveland for more than 20 years. It's a really enjoy the life there. So that my daughter was born in the Cleveland Clinic, and so we brought our son. My son, was born in the Catering Medical Center. So there's a 10-year, 11, almost 11 years difference. So my son, my daughter. So during my training, then you become a gastroenterologist. So it's an excellent training. We have a great mentor in Cleveland Clinic, and we have like a family. That time, Phil, now there's a lot of GI fellow. At that time, we have only 7 fellow total for
in the
3
whole
years.
program.
Whole program, 3 GI fellow, 1 liver fellow.
Wow.
So 3 GI fellow, 7 total. My year only 2. So that's why we are like a brother. We have it's like very close. We have share the same room, and then help each other with and then believe it or not, with the leadership, with the program like Dr. Falk, everybody has a first author in the gastro publication or hepatology publication.
Wow.
Everyone has like either AGA or ACG grant.
Wow.
So that's so that time actually there's a saga about that. So at that time there's AGA president, and that time AGA president, and there is a presidential address mentioned about we need to bring the bride and the best and the brightest back to the GI. Implied our class is some class. So we have actually 7 of us. 5 out of 7, we wrote a letter to the editor, ask that AGA president to apologize. So this turned out to be my first gastro publication. So that's a little bit of story, because basically if the GI fellowship in the dark stage, and if you still apply, that means we are the really die-hard fan. We're dedicated. We're die-hard fan of the GI. So basically, that's why there's a 3 years of fellowship is approved. And then Christy Medioni is the 3rd-year fellow. Actually, there's a Medioni score for the liver, fatty liver Medioni score. So there's a Christine. Mike Vasey now is a clinical chief in Vanderbilt. He's a leading expert in the GERD, and one of the top esophagists.
Yeah.
So yeah, so we have a great fellow and a great we have created this bond and
Right,
and
right,
then
right.
plus we have a very excellent program director, is um, um, Dr. Falk. Is already he's a little bit tough, but very have the high standard and lead by example. Actually, this is the one I would say. Probably he is the, if not the one of the, is would be the best program, best the fellowship GI fellowship program in the country.
Wow, and so it certainly seems like those were like golden years where it's like opportunities everywhere, and you guys were all highly academically successful. It's really impressive. Speaks volumes to the program that you were trained at. Now, tell me a little bit about you actually, because then you took that opportunity at Cleveland Clinic and you decided to do something very different. So, tell me about the specific mentors that you had at Cleveland Clinic and how you ended up doing something a little bit different than everybody else.
Thank you. So that you intended to go to join the Cleveland Clinic. You want to become a liver doctor or the hepatologist, especially in the liver cancer. That time, actually, when we joined in, and out of the 14 faculty members, 2 hepatologists, and mainly the clinical work, is the academic side not very strong. The strong side, actually, it is in the esophagus side and IBD side. IBD side is so you're at the first year fellow, and you basically you're energetic. You want to do the lot of research project, so that if every faculty member to talk to you, oh, hey, let's do the project together, it's always say, yes, let's do it.
Right.
So that happened to be the one of the faculty member is a Dr. Brad Lashner.
Okay.
He's an IBD director, and he is the second person to get an MPH degree in the field of the gastroenterology. So he's a second gastroenterologist get an MPH degree in the country. So he is a person, is a wonderful person. I consider him like Steve Jobs in the biostatistics. Make the simple thing, complicated thing simple. All the stats from his, digestion and teaching, and then makes everything simple and straightforward, easy to understand. So he came and said that, it's like I have a friend, he was actually also neighbor in Solon, Ohio. He's also a faculty member in the Department of Immunology. His background is pediatrician, MD, PhD. His name is Charles Bevins. Actually, this year he's retiring. So these two as a great mentor. And with these two, and then all of a sudden, their third person, probably the most important person in my professional life, is Dr. Phillip S, who is a leading colorectal surgeon in the country. So a leading colorectal surgeon in the country. So 3 of them come with the ideas because they always talk about pouchitis. So okay, it's like why the acute pouchitis of initial episodes of pouchitis almost always responded to antibiotics. Then so Dr. Bevins, the study, the focus on the innate immunity, penicillin, and its penicillin's own natural antimicrobial peptide that include defensin 5, defensin 6. So to believe this is a theory, is maybe some people with the pouchitis, because the pouch made from small intestine. Small intestine, normally germ-free. When you make the pouch, when your fecal stasis there, they may exhaust the production of the penicillin defenses. So there's a natural link. So then they say, hey, this new fellow coming and with the translational background, pathology background. Right. So then we said, how about a scientific project to study the penicillin and in pouchitis, with the defense in pouchitis. So we did several projects together related to defensin, pouchitis, and penicillin. And I believe we get even like 2 awards from the ACG. So then also in the meantime, I spent the time with Dr. Ferdo in his clinic, and I have the liquid nitrogen canister. So I collected the biopsy samples at Dr. Fair's clinic from the pouch, from the control group, from ulcerative colitis too. And then his OR in the operating room and the collected samples too. And during the sample waiting, you're standing there and then you watched how the Dr. Fair operates. Dr. Fair, and that he is a great master, a great teacher. He explained why I do this way and how big the pouch, I construct the pouch this way rather than that way, why I leave a little bit of mucosa there, the rectal mucosa, how do I handle the mesentery. So this that time is not a laparoscopy surgery, it's open surgery. You basically standing in front of the patients, and both the surgeon, chief surgeon, and the assistant. You can see the everything. And he painstakingly give me time to explain. Right. And they're outside of the OR, the way he talked to the patient, way he talked to the trainees, the surgical trainees, way he talked to the junior faculty, it stuck me. It's like that he is a person at the patient, they are great, he is a great Papa Bear. Played the comfort for all the patient, the family. He is so he's my role model too. So the way also that time, he introduced me in the clinic. He said, "Oh, this is to introduce me to the clinic, to the patient. This is Dr. Shen. He is world expert in pouchitis." So that's how started the process. That time, so 3 years training, right? Then during the 3-year training, basically we already had a 4th year advanced fellow. You during the 4th 3-year training, you do not have much exposure to advanced endoscopy. And you face the things like, should I do that? Complete my training for an additional year. So I decided it's like that if you without exposed to the advanced endoscopy, the training is not complete. So I did the 4th year, and encouraged by Dr. Greg Zuccaro. He's one of the best teacher in the iGIE, and that time is also Dr. Joe Richter. So I did become the advanced endoscopy the fellow. Then before we launch on to the endoscopy fellow, I try to get at least some of the training also possible from the getting myself ready for the 4th year. So I shadow and scope with the Dr. Ponsky, Dr. Jeff Ponsky, both invented the Ponsky tube. So that I did about approximately 150 pack tube with him. It's like it's so honored, such honor. Right. So when I do he teach me the 1-person technique, all the tricks. And when I do the 2-person technique, then when I bring a patient in the ICU, I would ask Dr. Ponsky, I had this pack tube before you could use step. Let me instead of get the patient ready so that I'll be here. So his things are like the mentality. These are master surgeons. They treat you like really like very. It's like their own fellow. Right. So then by the time I spoke with the Dr. Zuccaro, I sort of got ready to the EUS, ERCP because it's I probably did the ERCP maybe 300, EUS was 300. Then in the middle of the training, I faced a tough decision. Okay. You talk about September 11th, right? Right. So September 11th start. So that time, so you face this decision what you should do. So that's get a lot of people confused. Actually, 2001, the Congress approved some bill to allow the screening colonoscopy at age 50. Okay. Now, all of a sudden, there's a shortage of the gastroenterologists. The job opening everywhere. So that's actually, remember that after September 11th, right? I tell you a personal story. So the ACG started in October. And when I attended ACG, I checked the Hyatt. And he said, "You are Mr. Shen?" Yes. So, do you mind if we change your room? The room. There's the top one, a suite, presenter suite. Do you mind if go to that suite?
Oh.
Because at that time, nobody wanted top suite, right? September 11th, I said, take me in. Take me. So I have a 299. I get like a top suite.
Wow.
Because that time, after September 11th, that year, actually no fellow goes there.
No one wanted to travel, right?
No one wanted to travel.
Right.
But my statistics help. My statistics help because my statistics professor in China always told me, if the major events happen, the chance the next day, by the chance, events is much less. Same thing, I interviewed in the 2 weeks after September 11th, and so the Dr. Ponsky introduced me to Dr. Peter Cotton, because they had a job position there. So he's like so Dr. Cotton didn't ask me any CV, nothing. Dr. Michael Wallace was there, picking me at the hotel. So 2 weeks after the September, I flew from Cleveland to Charleston. That time is you go to there's a 130 seats jet.
Yeah.
There's 3 or 4 passengers.
Wow.
But when you go to regional jet from Cincinnati, from the Cleveland to Cincinnati, the Cincinnati to Charleston, there's a regional jet 50 seats or 4. So you went there. Actually, again is another master of the Dr. Peter Cotton. So then you face lots of options. Then also there are private practice options.
Right.
So it would be like your income 4 times, then you get offered from there. 4 times income there at the private. Now you really get confused.
Right.
So that's why I told my in the future trainees, when you job the decisions, first one would be you need to decide, do you want academic medicine or private practice? First choice. Once you decide academic medicine, the next one you need to find a niche. You want to find a niche, so that's how I said, okay, I did a lot of the research thing. If I do the private practice, maybe it's my previous background of the research background all wasted, and I want to give them my 3 years. 3 years as a try. Say if it doesn't work, and then I go to the private practice. I give the 3 year try. Then when we decided to academic medicine, now you need to find a niche. This is the most difficult one to find a niche.
Yeah.
That's why there's option would be: do you want to join as the hepatology, and do you want to join the advanced endoscopy group? So focus on ERCP, GI bleeding, or EUS, or versus do the IBD, but IBD with the focus on the pouch and endoscopy. So it took me a long time to decide which way I do. So then I sort of like keep in mind, I would say, when I do the successful as being a successful academic medicine, there's one rule would be, in what's the situation during DDW, there's a topic about ERCP with somebody invited Dr. Shen to give a talk. That anticipated because my mentor has not been invited for the ERCP for a while. So what's my chance? It's very unlikely, right? So that's why we said, then maybe the area it's not my way to do. So we took actually the pouch as a project. So the pouch project would let's say because there's a patient population is a demand. There's a gap because the pouch condition has not been systemically studied. It's here and there. No, there's not like a field yet. So later on, what I call it become the maturity field called pouchology, right? So we say it's not only we are studying the pouchology, but any other pouch disorder. So the target would be the niche with translational research on the pouch disorder. So I have a career development board on the pouch disorder from ACG, and also had an NIH grant for study irritable pouch syndrome with the NIH grant, and study the use of Barrister mental health and the study. So use the multidisciplinary approach, so that when you join the faculty, you have 2 grants to give you a protected time. The time is 40%. Then next step, they establish a pouch clinic. That time we'll call it pouchitis clinic. So then you study the patients. You at the end of the day, after see the patient, you do an Excel sheet. You do the own database. You enter the database at evening. I'm not very good at the computer in terms of the fancy program, but I know Excel sheet. So
right. It's good enough.
So that time was okay. So then all the clinical study, the data is from there. Pouchitis, later Cophitis, Crohn's disease, pouch, medical field. To study from clinical side first, then go to inside to the translational, then to the bench.
It's very interesting, kind of, because when you look at your career, during that stage in your career, you were very strongly influenced by Dr. Fazio and by all your by the colorectal surgery relationship that you had, which is very, very unique. And I think that kind of drew you into, especially with your basic science background and your translational background, it really drew you into the pouch as a academic interest, even though you were trained as an advanced endoscopist, right? I think it's one of those things where one of my mentors, Raju, who we both know, by the way, he sends his warmest regards. We actually
he's a wonderful person.
We just met today. Right.
Actually, he was trained in Cleveland area too. It's a UH. Yes.
I know. I know. It's a small world, but I remember one of the things that he told me was keep in mind that your academic interest and your clinical interest may be somewhat separate, right? They may not necessarily be completely aligned. I feel like you're a very similar situation where you had an academic interest in the pouch, going back to all your studies on defensins and Paneth cells, and then kind of as you started thinking about a career, wanting to actually sit down and focus on the pouch itself. Unusual move, because most people, like you said, when they come out of advanced endoscopy training, especially if they've met Peter Cotton, they come out, wanting to do only ERCP. Kind of like our last interview was with Todd Barron. And so it's like, and then we have you. But did you not, let me ask you this. Were you not afraid when you started your career, or I guess because you had such a well-rounded training from back in China that you really didn't have the fear of knowing what happened if you decided to do something so different that you failed?
So it's actually you have a scare.
Right.
It's common. It's a feeling. It's like, but you have enough confidence actually with your. I always believe as an endoscopist, as a procedure-based specialty, especially surgery and endoscopy. So the top one is the core principles. Second one is technique. Third one is device. So, for example, I use a surgeon, said a Crohn's disease patient, right? You have the perianal disease, right? The disease of rectum. You have to do the stoma, right? Should we do the colostomy or should we do ileostomy? Most people, if you don't understand disease colostomy, right? Because I need to use enough more colon, and rather than just give ileostomy. The correct is actually ileostomy. That's why it's a principle is important. Principle actually also tell you, in that situation, should you do it or should you not do it? I give you an example. So when you treat the structure of the IBD, now, should we put a stent there or should we not put a stent there, right? We know if you have a colon cancer, you have to put a stent to relieve the pressure, they give the bridging to the surgery, right? And then you use uncovered stent, so you have this secure. For Crohn's disease, so that technically you can put a stent there, but by principle you should avoid a stent. I tell you why? Because the covered stent is not strong enough for the tough structure like Crohn's disease. Number one. Number two, if the stent migrates to the distal part of the bowel, if people with Crohn's disease, you can cause a fistula. So that a lot of the young people say, oh, let's do the stent. So this is the principle. What you should do, what you should not do, right? So that's you need open-minded. Right. So this is the background. Actually, I also encourage procedure-based, such as endoscopy. Spend more time in the OR. Touch the surgical specimens.
Yeah.
See what's the resected specimen structure, fistula look like. Feel like how deep they are. That can tell you when you do the structurotomy how deep you go. So that's things like that. And then, of course, with the teamwork is important.
Yeah.
That's why the great mentor like Dr. Feather, we started into the structurotomy, sinusotomy things. Dr. Feather is behind. So watch it. And then you have an open-minded surgeon. But this, you also have these things tricky part, right?
Right.
So surgeon has to say, oh, they may say, Bo, don't waste your time. The structure, let me do the full surgery. So you need, in order to advance your field, you need to work with the surgeon. Just my personal experience later on, we say, if you are the build up the team, probably medical team or endoscopy team a little bit senior than surgical team. Because if the surgical team, in my case, probably with the Dr. Feather, I cannot argue with the Dr. Feather. But later on, after Dr. Feather retired, I typically work with the young faculties. Help with their career. At the meantime, you can, at the endoscopy, they are sort of like respect you. You know, you say, oh, this is things like the pouch prolapse, right? Should we do the banding, or should we let the surgeon do the banding for banding or the plication? Then, with your knowledge, actually, you work with your little bit junior surgeon for that.
Right.
So, that's one of the
and it really helps to build that relationship that you have between yourselves and your colorectal surgeon. So, no, so absolutely, I think you were definitely in a very you were in an environment where it was very nurturing for you to grow a very, very unique niche. So tell me about your early career and how this concept grew, because originally you gave yourself a 3-year clock. You said either it's going to make it or that's it, right? But clearly you made it and more.
It's a natural evolving. So my time, so I'm studying pouchitis, inflammatory condition of the pouch. But then you see the pouch things, right? As in the meantime, the people had a pouch inflammation. In the meantime, had the stricture. Actually, fecal stasis can cause a pouchitis. And then also later on, this is also people had a Crohn's disease-like condition at one of the differential diagnoses had the stricture fistula. You have a caphitis, then you have the and then more and more you see the more of the patient actually there's a surgical leak. So later on, we found out that most of the pouch disorder, we say maybe 80% are technical. So then you're dealing with the pouch, not only an inflammatory condition of the pouch, like a pouchitis, caphitis, Crohn's disease of the pouch, or functional disorders such as idiopathic pouch syndrome. Now you're dealing with the structural disorder. Structural disorder in the pouch, there are two main categories, either obstruction or leak, right? Obstruction like an asthmatic stricture, like a pouch prolapse, pouch twist, right? Obstruction. Like an asthmatic leak would be a chronic leak and acute leak. Chronic leak, such as a sinus fistula. Acute leak is the abscess. You have all the tool. You can fix it, right? So that if you have the sinus, you do the sinusotomy. You do the if you have the fistula, the fistulotomy. If you have an abscess there, right? Remember, if you have abscess, acute surgical abscess, what do you normally surgeons do? Transcutaneous drainage with the IR, right? Put the big mushroom catheter, the JP catheter to drain. You know what? This an asthmatic leak, you can put the internal drainage. Just simply put the pigtail stent.
Right.
Drain abscess internally, so you avoid like an the intercutaneous fistula. If you drain outside. So you have the things that you build up the relationship. Once you do the build of the relationship, I can tell you, if you, as an endoscopist, you rescue your surgeon for a couple of the leaks, you'll become best friends. Because at this correct, the low GI tract is, why is it hard? Because colon has the least blood flow, and anastomotic complications happen. Now this anastomotic complication 3, right? Leak, bleeding, and stricture.
Right.
You cannot go back to do the surgery again. Why? Because this already ischemia. How can you resect there? The bowel becomes the messenger pattern shorter, and then even more risk of ischemia, right?
Right.
So now, as an endoscopy, you can rescue your surgeon from another surgeon, right? Rescue the people, the patient from the permanent stoma. So that's your reputation. Actually, I've been invited to the surgical community to give talks. I have Brazil, they have this, what is it called? Some award, the national award, Tobacco Code Award, the surgical community. So you work with the surgical community. So, and in the meantime, you also don't forget your pathology background, right?
Right.
So you're also interested in the pathology things when we do the surveillance, because the pathology background is important to how do you survey people already had the microsectomy and anal transition zone, and then basically all flat lesions. How do you to survey the people with the called top down, the button up dysplasia? That means the dysplasia already underneath the submucosa, and then only on the tip, the mucosa area has some, atypical indefinite dysplasia. How to detect it, right? So your pathological background will help you. So every day, the field I could go back to your things about this. How do you do the clinical research? Raju is right. When you sometimes do clinical research and the clinical practice, maybe not close each other. For example, if I said, I want to study the obesity and with the Crohn's disease. Okay, great. You may in the future see that a lot of Crohn's disease, the obesity, you develop a niche, right? How about the things I'm also studying smoking and Crohn's disease. Now, my view is that what's the chance after you develop expertise in the association with the smoking with the Crohn's disease, the doctor will refer to you because you are studying the smoking with the Crohn's disease.
I see.
I always keep this in mind. What's the chance I could refer the people in the CKME you have the expertise? Because nowadays people sending me to me basically, I have a blockage, and asthmatic. So my study my clinical niche is a structure therapy, right?
Right.
So especially an asthmatic structure therapy, right? So that people like that. I study structure, and asthmatic structure, primary structure, and then people refer to me because of structure.
Yeah, it's very interesting because by that it kind of goes along the progression in your career from the pouch clinic and pouchitis, and then to what you coined as interventional IBD, and then now your most current concept, which is corrective endoscopy, right?
Yes.
So to tell me a little bit about the highlights of those different categories that you've come up with.
So there are 3 stages in my career after becoming a gastroenterologist in the United States. The pouch disorder is one stage, it took me 10 years. And the second stage is interventional IBD. Third stage is a corrective endoscopy in colorectal disease and IBD. So basically, from the concept, you have a pouch clinic, you manage the pouchitis, and in addition, you manage structural neoplastic complication of the pouch. Then you do the structurotomy, sinusotomy, fistulotomy, placation of the prolapse, etc. You use the same technique to extend to the IBD in general, that including Crohn's disease, ulcerative colitis, right? Crohn's disease, a lot of people had the surgery. You had the primary structure or disease-associated structure, or the surgery-associated anastomotic complication, bleeding, leak, and the structure. Ulcerative colitis, same thing. You would have the structure too, and also the patient had dysplasia, right? According to the ESD, EMR dysplasia. So you started with IBD, then it's a whole area of the interventional IBD.
Wow.
Over the years, interventional IBD now the 5 category of the indication.
Okay.
That category is expanding. Each year we're expanding. First category is the stricture, right? Striculotomy, prolonged dilatation. And the second one is a fistula. So fistula or abscess treatment. Third category is what we call intraluminal lesion or mass or material, such as a trapped capsule endoscopy, such as the mucosal prolapse, such as the fecal transplant through the scope intraluminal. Third one is IBD surgery associated indication, such as anastomotic leak, anastomotic stricture, and anastomotic bleeding. And the fifth category is a colitis associated neoplasia. We're talking about polypectomy, EMR, and ESD, and then that area is keep growing. Now, talk about the next stage, what we call corrective endoscopy or corrective surgery. Basically, you use the endoscopy technique to make the correction at the backup plan for the endoscopic complications, such as if your colleague has a perforation, you go there to fix the perforation, endoscopic perforation, right? Or use corrective endoscopy to dealing with the surgical complications, such as anastomotic complication, anastomotic leak, stricture, and bleeding. Other way around can be true, called a corrective endoscopy, a corrective surgery. If the pouch was wrongly or poorly constructed, you redo the pouch or converted one type of the pouch to other type of the pouch. So then you expanded the area. Remember, MD Anderson, right? You have a lot of your institution had a lot of rectal cancer. I can tell you, your friend will be like your oncology, the surgical oncologist surgical surgeon will be very grateful because I dealing with the things all the time. Rectal cancer, I hate it. Why? Because low anterior resection and the low anterior anastomosis and then plus radiation. Leak stricture is common. So, and then most of those patients do not have another surgical options. So that means like as a doctor, you and me, we can, like I call it like Tom and Jerry get a corner. Because of the institution like MD Anderson Institute, like the New York Presbyterian Hospital, Columbia, we don't know where to offer these patients. Nowhere to offer. You are the last expert here, right? So you corner the cell, then you need to come up with some, technique. Actually, sometimes we can use some technique, use the upper GI tract or the hepatobiliary pancreas. There's some tools, the technique for dealing with rectal cancer. So that's
it's very interesting, and that really kind of ties into the fact that you have such a well-rounded endoscopic skill set as well, being an advanced endoscopist. You kind of think about these things in ways where a traditional IBD specialist would not, would never really be able to come up with.
Yes. I actually feel it's like an ASGE should be like we need to do the better job to fill the gap, right? So we have a community, IBD community, and nowadays a lot of the IBD community focused on the drug therapy, right? You know what? Drug therapy, long-term use of drug can cause stricture too, right? Rapid healing, right? So then, advanced endoscopy nowadays is of course pancreas, esophagus, and the bariatric things. So there's the gap we have to, you and I, work harder to fill this gap. So I see the trend. All IBD interventionalists so far, their background probably mainly is IBD background rather than the advanced endoscopy at the background. So in the future, we should have a split. Advanced endoscopy interest in IBD should be 50% in the field of interventional IBD, and the IBD specialist interest in advanced endoscopy should comprise another 50%. And in the middle, maybe have involved a surgical endoscopist too.
Right, right. I was going to say the parallel is kind of like, people, for example, who do like third space endoscopy work, right? There are some who are surgeons, there are some who are advanced endoscopists. And I think it's almost like it's a very interesting parallel. But yeah, that is a very interesting question to ask you in terms of how do you envision growing this field? Because now, this is a field that's really associated with your name. And if you asked me to name all the interventional IBD people I know, I would have a hard time naming more than several people. But like, how, what's your vision for how do you grow this field?
So this maybe start the program is hard. You need a patient, right? So when I started the pouchitis clinic, pouch center, the yearly patient visits for the pouch disorder, 2002 or 2001 is 64. And by the time I left the Cleveland clinic, my yearly visit for the pouch disorder is about 3,000.
Wow.
So
the need is there.
Need is there. So you do not have this. Oh, everybody want interventional intervention endoscopy in IBD. I believe each big city, like Houston, you should have at least 2 or 3. Mm-hmm. And each big city and each medium-sized city, such as say Columbus, Cincinnati, should have 1, right? Mm-hmm. So then then you accumulate it. We call it it's actually center for excellence, right?
Right.
So that's where we very focus. I believe maybe it's not the politically right saying this. Now a lot of the community hospital even do the liver transplant, right?
Right.
The outcome should be like you constitute a large hospital, large volume, and then provide the best result. Interventional endoscopy is the same field. It's like in New York City, we have a couple of them do the interventional procedure in the IBD. I think this area to need more training, expanding, and then it's from the IBD community, right? So the IBD community with the iGIE. Actually, all iGIE said during the DDW, and the majority of the talks on the medical side, a little bit of surgical side, not much of the endoscopy side. Actually, endoscopy side is the ASGE during the DDW. I just give an example. So that's resources. The distribution is important too. You probably had we run ASG run some animal lab, more of the another thing I forgot is about the famous RBU. As a gastroenterologist, right? And you are the
That's
pressure.
True. That is true. There's a
I can tell you the pouch endoscopy 1 IBU. Okay.
Right.
So more IBU never
that does influence career choices. That's true.
Or very career choices. So you have the pressure with that. I think it's the tricky part. I have the couple of the trainee and negotiated nice RVUs. Mm-hmm. Nice RVUs like simply for the pouch endoscopy with the structurotomy, they get at least 10 plus RVUs rather than 1. So that's why you need institution support too, and then with your innovative procedure. So that's why the RVU actually I have one of the former IBD fellow. Actually, my first IBD fellow contacted me last week. Asked me, said, "Oh, how do you, as an IBD person, now we have the IBU pressure. How do you improve the things IBU because there's a lot of pressure from institution, right?"
Right.
I give them the same tricks. If you have it from the endoscopy perspective, you need a modified IBU with your own institution that already has some successful story for that.
Yeah, and it's interesting because when you bring that up, it does kind of make you wonder, in terms of growing the field, whether that push to grow the field may actually need to come from the medical IBD side, right? Like you were saying.
Right, the medical IBD side. So you hopefully get people more interested. Nowadays, they are merging for that. For example, the drug-coated balloon, right? You almost
Yeah.
mingle with the medicine, with the endoscopy technique. It's starting. And actually, there's will be like a gap, right? We already see for ulcerative colitis with aggressive, effective medical therapy, the colectomy rate is dropping.
Right.
Right. Now, you anticipate in the future that for colectomy as an indication, dysplasia-associated complication will happen as an indication
Correct.
for colectomy increase. How do you foresee that? How do you develop an endoscopic technique to remove that, right? You can also see the people with also Crohn's disease too, right? Years of Crohn's disease, all of a sudden, the refractory disease drop down. This patient order maintain, and there's after 5-10 years gap, people either develop called mucosa healing, just diffuse mucosa, right? Mucosa scar, or you have diffuse pseudopolyps.
Right.
Or later on strictures. Structure that benign can be malignant structure, or later on develop cancer things, right?
Yeah.
You can foresee these things. For example, the people coming here nowadays, disease well controlled. Then you have a 20-30 of the pseudopolyps, the very juicy polyps, but it's an inflammatory, post-inflammatory polyp. You can see the disease in remission, but they have anemia because of polyp, right? How do you survey those people? How do you do the colectomy? How do you do the polypectomy? Actually, in our practice nowadays, if the inflammatory polyp greater than 1 centimeter large, we all remove. For the purpose of the eradication dysplasia, help the anemia, help the blockage symptoms. So this is another field for the interventional IBD you foresee what is coming from the medical side of the IBD.
Yeah, so, and I would imagine you probably do the same for IBD-associated dysplasia too, right? You just kind of endoscopically start removing these things.
Remove the things, and then also this like the imaging technique, right?
Right, especially as like endoscopic technology has gotten better, the doors have opened for you to be able to do these types of things, which might not have been possible to do earlier in your career.
Especially these things, I think that you see. Interventional IBD problem is maybe focusing the major academic center.
Yeah.
I cannot foresee this like the private practice or maybe some of the largest single specialty groups such as the iGIE, Atlanta Gastroenterology Association. They may afford can do this subspecialized interventional IBD. But
sure.
Now on, it's like if you have the endoscopies, this is the field. It's if the iGIE, SG in the future will run the workshop for the people like career development. By the way, we're grateful for iGIE already established for special interest group for interventional IBD. So this is all very helpful to attract people trying to find an academic niche in the area.
Yeah. Just out of curiosity, just because you're such an outlier, do you find yourself closer to your surgeons or to your medical IBD colleagues or to your advanced endoscopy colleagues?
So a mixed actually. So we have a setting at Columbia actually.
Yeah. Tell me about this arrangement. But actually, it's perfect timing. Tell me about your arrangement at Columbia, because this is very unique to you as well.
So this is the vision of my former colleague. Now it's my close partner, Robbie Karen.
Okay.
It's New York is a medical IBD. There are 5-6 institutions to run the medical IBD.
Right.
And in order to attract the patients, in order to be like you make yourself marketable, and then you need to find a niche, right? So the $10 to be like the endoscopy interventional IBD is a niche. So and then you work closely with your other colleague at the Cornell. We have a Cornell colleague and then. Columbia colleague.
Okay.
So that Cornell is a very their strength in the medical IBD, where the strength the surgical and the endoscopy work very
I see.
Closely. And then I share the clinic and the side by side in our same office and the same clinic with our surgeons. So then we do lot of intraoperative endoscopy too. If the people have the multiple structure, rather than get the bowel resection, you do the intraoperative scope, and then people, let's say, if the people had the quick blockage, totally blocked by IBD, you need a surgery. If you do the endoscopic, introduce the rectal tube there, or NG tube through the anus. We do all this all together all the time. So that's a setting would it be. So how do you build up the IBD program? We have a little bit of business secret to you. So the way we attract the patient in New York or the out of state, it is called spillover.
Okay.
So the people refer to you because of blockage, or surgical leak, or access. Okay, you have expertise. So we treat the patient endoscopically or surgically, right? Now there's a post-procedure care. The patient are on a biologic agent. How do you manage it, right? So you have a way to send it back to the patient, to the referred doctor. Most of the time, because of complexity, patient want to stay with you. You provide a good service, right? So you do the medical, take over the medical therapy, infusion, injection, etc. So go to spill over. Post-surgical, the same thing. This is a great business model, and the patient doesn't have it.
So do you do the medical IBD as well?
Yes, we do infusion. Yeah, we do infusion too.
So you're on top of all the new medical treatments for IBD. Like in addition to all the interventional IBD stuff you do, you're still well versed in all the medical IBD as well.
Medical IBD, never forget the IBD. I do that. So I also interesting like the not only spend more time with the surgeon, or spend more time with the pathologist, and then spend more time with our radiologist. Actually. So the build up the team is important, and not only you are in the IBD team, you need to go to pathologist, go to surgeon, but you also need to go to urologist because we're dealing with the pelvic organ, right? Right. Because the next, you need to go to the GYN, OB doctors, and go to nutritionist and mental health specialist, right? Then, in addition to the medical side, you need the dermatology, rheumatology. How do you build up the team? And with the same important one, the same mentality, and they work very. So, for example, how do I pick a radiologist? Actually, radiology not only expertise. Second one, you need help me quickly. For example, if I have a difficult patient, it said, "Oh, there's a structure there. I want you to read." It's help me guide it. How do we treat it? Right? You ask the radiologist, "Could you read the film for me?"
Right.
If she or he said, "I will read it within 5 minutes," after several occasions, yes, that's my team member.
Yeah.
So you need to be
it's a reliability.
Reliability.
No, very good. I would imagine you don't do EUS ERCP anymore, do you?
You don't do ERCP anymore, but we tried to do the intestinal ultrasound and the new field. Actually, during my time, we did I did the intra vivo ex vivo study with the Dr. Shen. We use coherence tomography ultrasound probe to treat to measure the surgical samples. So this was, but the technique is there, and then I have that mind on that too. In the future, probably we use some OCT technique to detect the fibrotic structure with the open-minded. Actually, in the field, there's a recent advance, right? So how do you measure structure, right? Radiology measures structure, and the endoscopy measures structure. You probably have these things all the time. Radiology said there's structure. Then you go to scope there, there's no structure. Or radiologist said it's a 5 centimeter structure. You go there to 2 centimeters, and with your scope. Now, how do you to make the piece of the both? So open-minded, for example, we routinely use nowadays for low GI structure. We use endoflip. So that's give you this more accurate, more objective things. So you're open-minded because endoflip is what? It's esophagus tool.
Right.
Now, often become my IBD pouch tool and a rectal tool.
It's so interesting because I think it's just because of the way that you're so open-minded about this, you're able to adopt all these new techniques, but then you view it through the lens of an IBD specialist, because fundamentally, I think, you mentioned this earlier, you kind of think on a higher level in terms of like disease rather than just procedure, or rather than just devices. You're thinking disease, like global, like disease.
Correct.
And because of that, you're able to view these things differently, and draw all these tools based off of your training, and based off of how you view new technology, and you kind of see how you incorporate them into your practice. Actually, tell me a little bit about how do you decide to incorporate new things, because I know you have a slightly different approach even to DDW. You have a slightly different approach even to publishing and starting with case studies and whatnot. Tell me a little bit about your academic approach and how you invent things, so to speak, and bring them into your practice.
The inventing things like it all started with it being like the physician.
Right.
I thought that that field expert, you either become a cornered animal. So that means you don't have nowhere to go, and the patient has no other options.
Right.
So the patient become cornered animal, you become cornered animal, no options. So what means a cornered animal? That means, so that in our field, it is, you started the medical therapy, failed, endoscopic therapy.
Right.
Endoscopic therapy failed, you do the surgical therapy. How about the surgical fail? And then the patient has no option. I give you an example. So patient has a bad Crohn's disease of the perianal disease and the rectum, right? Now she also has a little bit of small bowel disease, and then now he has to carry the stone. Little bit of rectum left for years. Okay. You remove the rectum, then you have the risk of persistent perineal sinus. It's about 40%. You make basically in the pelvic area, there's a big hole. Okay?
Yeah.
Now, if you do not remove the rectum because of fecal diversion, right, you have the stricture. Can be rectal area totally sealed. So there's no surgical option for them. Not a great endoscopic options too. Then what do? You just, when you have to sleep, you think about the tool. When you do the talk to your colleague in the other field, do we have any other tool besides the structure therapy with a knife, with a bougie, with a balloon, with a stent? So you're open-minded. So every day the innovation started with your become corner. There's no option for them. Then you know what? So if there's someplace you are dealing with some of the pediatric patient, I saw it, right? The parents say, Dr. Shen, where's end for my daughter? Then you really become sort of like emotional as a father.
Yeah.
You really get something, right? So open-minded, you ask around actually during the TDW, during the other meeting, the ASCA meeting, the American Society, the Colorectal Surgery Society meeting, you're looking for that, like to listen to any new tools, right? So once you find that the tool is effective, you publish a case report. Let people, the community know there's an option for that. Then over the time, if you watch for that, and then you over the time accumulate it, and then say the 20, 30 patients, then you publish as a case series, right? We have the registered for this one, RRB registered, publish all the case report, the case series. And then later on, if you're doing good, you know what? You can compare with the surgical approach, right? You have the case control. And then next one, if you do not, if you do want to go further, you can do the cost-effective analysis, right? You compare. And then if you are fortunate, if there's some device company interesting on this not a common disease, sponsor you have the randomized controlled trial, such as now we do the run drug-coated balloon for the stricture. Then you do randomized controlled trial. That's how to evolve in that field. Starting with the case report, starting with you being cornered.
Right.
After surgical fail, you're cornered, you need to figure out something. But to figure out something, how do you use the tools, right? Your tool as a technique device actually already FDA approved. For example, we use a needle knife to treat people with sinus, right? So resect or something. What's the needle knife for? The needle knife is for the ERCP.
Yeah.
And also, I believe that Phil, your guys, the ERCP is more difficult than my scope downstairs in the lower GI tract, because papilla is so delicate an organ, right? As compared to people with the bowel, right? So that's why it's once you do the so-called innovation, use the available FDA-approved agent. For example, I use esophageal bending things to treat it with the pouch prolapse.
Right.
Right? But say, what this came from? You know what? So you started with the people had a pouch prolapse, pouch flip. They already failed the surgery to fix it. They have a PAXI, they have a mesh, or fail.
Yeah.
The patient had no outlet. You cannot claim the pouch failure, because when you take the pouch out surgically, just claim the pouch failure, it had complications such as this persistent pain in sinus. The patient had no outlet. Now, if you have the failed surgical treatment of prolapse, now we're doing endoscopic therapy, because mucosa banding, right? Minimum side effect, right? Now, we used to have use endoscopic technique, treatment, say pouch prolapse, as a backup for surgical treatment of failure, right? Now, people ask, why don't you try your less invasive first?
Right.
Now, all of a sudden, the endoscopy become the preferred choice than the surgery. That's how these things evolve, right? Used to use area as a backup for surgical failure. Nowadays, we use these things to treat further. Same thing to the stricture. Anastomotic stricture, should we let the surgeon recut and redo anastomosis? Or you treat the endoscopy if the endoscopy failed to have a surgical therapy, right?
Yeah.
So that's why how to involve initially, you know what? When the people had the primary stricture, they do the cut, they have anastomotic stricture, right? Then you do the endoscopy therapy, right? Then the surgeon said, oh, there's any blockage. Why not try the endoscopic things first? Right? So how the things evolving, you become, as I will say in endoscopy, right? You are starter or bench.
Right.
Like you play basketball, right? So endoscopy used to play at the bench. Surgery is a starter. Now all of a sudden, rule is flipped, because we provide something less invasive, right? But a more definitive therapy than the medical therapy because of structural complications.
It reminds me of a couple of things. You know, when we interviewed Bennett Roth for this series, his quote was, "Need is the mother of invention." You know, it's a very exactly. It's a very interesting. And then even several of the other people that we have interviewed for this series have commented that, you know, even like maximally invasive endoscopy is still more minimally invasive than minimally invasive surgery.
Yeah.
So it's a very interesting perspective, and I'm so glad, you know, the field is so fortunate to have someone like you who thinks that way, because, you know, it's still to this day it's a minority of people who think this way. So it's been an extremely enlightening interview, and I'm going to change the topic here, because, you know, I think you and I have several things in common. Well, one is that we both, because we're Chinese, you know, we both have high expectation fathers. And so let me ask you this, given everything that you've accomplished, you think your father is proud of you?
Yes or no? He was proud of me because I'm a sort of a dual professor in medicine and surgery. Yes. He was not proud of me because I didn't take his track to become the liver cancer doctor. I basically didn't do anything much about the liver cancer research. He's a little bit disappointed. And then his idea always said, you need to figure out the disease mechanism, number one. Number two, you need to save people's lives.
Right.
So if you improve the people's life, quality of life is not good enough. But that's sort of expectation actually motivated me. But it's like I would say it's the father as a role model, and you are his mentality and his innovative idea and his open-mindedness, and he is actually. My mother and my father never give me a hard time when I have the score was not good in the school. Okay, so I can tell you when I get to go to the medical school, actually, that most of the people said, even my high school teacher, that was he just the boy is lucky, boy is lucky. So
Well, I
these
mean,
things, yeah. So that's, but I think it's they are not the classic tiger mom things like the or tiger father. So this, I think it is another things I learned from my father. My father is very good to write the article well, and then I like to write the article, write the paper, write the
books.
the books. Yes.
Right.
But one day I tried. If I can write a book outside of medicine, I'll be very happy, because so far all medicine book. One day I may read the cooking book or the travel book. Yes. So
that would be nice. That would be nice. I mean,
yes.
I mean, like you probably have plenty to write about for cooking. I think we talked about this before offline. But what's your favorite Chinese dish or in Chinese cuisine?
A lot of the Chinese cuisine. I always say is so you go to the Chinese store. What's the most expensive vegetable you pick? Actually, most expensive vegetable called a baby green shark. Baby green shark, and that's things that if they make egg roll. Egg roll should be made from the rice paper. That fried egg roll I can do the dozen. It's like this is my favorite. So when I go to the Chinese restaurant, anytime people serve me broccoli and broccoli and the cabbage and the carrots, I think this restaurant too cheap. So if you send me bamboo shoot, fresh bamboo shoot, but a bamboo shoot, legit. Yeah, so there would be like really. These things you go to like the Turkish restaurant, right? Some people like some of the food that you go to Italian restaurant is that they're really truly authentic or not. I really need some dish I need to judge. So if I go to actually in Cleveland, there's a restaurant called Hunan East. There's a dish use a baby green shark. The only restaurant I've met in the United States save that dish in the restaurant. So that's give you a little bit of price, okay? So that price is nowadays in even like the big Chinese grocery store, it costs about $10, $12 a pound. Yeah.
Wow. Yeah. And I mean, but I mean, I think the food, I think culturally, it's kind of like very similar to like Shanghainese food, right? Because I think Qidong is kind of near Shanghai, so I think that we share a very similar. I think we kind of share a similar language and similar culinary background.
Correct. It's a that's area actually the Delta area is very rich because the Delta area is from all the water come from the river. And in that area, you have in the area had ocean fish, sea fish, seafood. You have the lake fish. You can have the river fish. So it's a lot of a variety. Actually, it tell you that if you go to visit Qidong, if you say that you are honored guest, if they serve that food for you, that is honored guest. What they call we call pine tree in the bottom of the sea. What is made is from tentacle of the jellyfish. They make soup.
Okay.
So if you get people, I call it hike. So this will be tentacle of jellyfish. They make a soup. That one is the most expensive things. Another one is the clam cake.
Okay.
They would make the clam, fresh clam. They put wheat and a little bit of flour and a little bit of eggs and fried.
Is that the jellyfish? That's the crunchy one, right?
The crunchy one. There's a crunchy one in the surface. What we crunch is with a salad. Salad is also famous. It's the Qidong salad. It's a crunchy one.
Right.
It's a salad. Actually, it's delicacy. By the way, Qidong people, if you curse some people, you use the word, oh, you're jellyfish. But it's a jellyfish is also the delicacy. Jellyfish, why? So if the people say bad, well, you're like a jellyfish. So that's why my WeChat, actually the nickname we call it Qidong jellyfish.
Oh yeah.
I just think it's sarcastic.
What's it called? 海蜇头.
Why we call it maybe it's because the jellyfish is the low animal.
Because it's like bottom feeder.
Yeah, because eat and secrete from one hole. However, the jellyfish, the top part is our local delicacy, and the lower part is that's
Hai Zhe is it's a delicacy in Chinese cuisine. It's a very.
But now it's like if you go to like the Flushing, go to this Chinese, this is not good because it's chewing, not crunchy.
Oh no, that's not right.
The chewing, not crunchy. So
that's not right. It's supposed to be crunchy.
Yeah, so it's a low quality. So that's why I have a high standard for the.
I'm sure you do.
Yeah.
So, are you a tough dad to your kids then?
So actually, I'm probably not so tough. So I probably a little bit high demand for my son and my daughter.
Do you consider yourself like a Chinese American dad or still like a Chinese dad then?
I think I look at the Chinese American dad. Actually,
so it's inevitable, basically.
Yes, basically, as my mother, my wife, and I, as like not the classic, the tiger mom like that. It's my feeling is as a parent, you lead by example.
Yeah.
So, but it's like your core value, your work ethic, and your mentality is like the so we are so proud of our children. It's like the same mentalities. Work hard, be nice, and also friendly. Always want to help. It's a precious. It's a precious. And plus, my son and the daughter is very close. They are 11, almost 11 years difference. They are very, very close.
That's good. That's good.
Yeah.
And it's so interesting, because these are the same values that your mentors had. Right, and it's very similar. It's very heartwarming to hear that these are very, very similar approaches. Parenting, mentoring, they're very similar. So, again, just kind of bring things full circle here. I want to thank you again, Bo, for really a phenomenal and very deeply insightful interview. And I ask this for every person that we interview for this series is, your closing thoughts in terms of, personal advice and wisdom. Like, what advice do you have, just a couple for future generations who want to be as bold and innovative and impactful as yourself?
Thank you. So I would say it's learn from my lesson experience. I would say it's the first of all. It's like you enjoy taking care of the patients. And all in all, we should be grateful for patients' trust, encouragement, and also you have some empathy for them and help them out. I would say, if especially you are an expert in that field, I would say it's like my Dr. Fazio. It's like your Papa Bear for all the patients. They have you. Give them all the comfort, all the support for them. You have to love your patients, and then actually, you help the patients. Patient help you. They help you in what degree is more than you help them. For example, in my early years, right, I need a lot of grants. From the federal government. from the institution to support my research. Nowadays, all my research is supported by philanthropy, from general support from the, including my professorship is a general support from our patients, the philanthropy. So the second one, if you always, you need to, especially in academic medicine, you need to polish your skill. Polish skill you need a multidimensional. The first one, you need to know the bench science, translational, clinical, and outcome research at your core. And the other dimension it is open-minded is different disciplines. You are gastroenterologist, but open-minded within the gastroenterology. You may have even the gut IBD person, you may have the field of hepatology, such as the primary sclerosing cholangitis with ulcerative colitis. Learn something from your GI colleague. In addition to that, important one, you learn from your surgical colleague, radiologist, pathologist, urologist, gynecology, OBGYN, other doctors, and other field. You need it. So the different subspecialty. Another setting would be, it's very hard for the young people just finish training, you find a niche. If you don't have to find a niche within your department or within your division, within the same section, if you don't have a niche, look for outside. Mm-hmm. I always tell my patients, say, I'm from me, the average program is not natural resources. So how do you find a niche? The find a niche would be, you need to find, say, your institution, which program you can say ranked number top 5 in the country, and see if the connection to your field. For example, IBD field. There's an institution talk to me. Oh, there's the young faculty talk to me. It's an IBD person, right? Not a big program. I asked them, who is your institution had the top subspecialty in the country? Oh, we hired a person with the multiple sclerosis, who is the nation's leading expert, international expert. You can collaborate with them for the IBD, right, with the multiple sclerosis, right? So same thing when I used it many years ago, used the IBD, I used a strong program like Dr. Shen program. So, and in order to be successful in the academic medicine, you have to enjoy writing.
Yes.
Enjoy the writing. How the things are put together. It's not too late. Ideally, if you do that, you polish your writing skill during the medical school, during the early residency and the fellowship. But if sometimes you have not independently write the paper as a young faculty yet, sometimes you may be too late, because that time, even you have the senior mentor to help you, senior mentor may be reluctant to give the critics to your paper. So when you started writing, started as a resident, as a fellow, and enjoy writing.
Yeah. No, thank you very much. I mean, I think this is just is really a wonderful advice from a wonderful mentor like yourself. And just want to really thank you for taking the time to do this interview. This will be published in the September 2025 issue of iGIE. We look forward to seeing the published version online. And again, thank you so much for taking the time to do this.
Thank you much. Thank you, Phil. Thank you for having me.
Thank you.
Thank you for the opportunity.
Of course.
Thank you.